Hi, I'm Dr. George Bakris, Professor of Medicine and Director of the Comprehensive Hypertension Center at the University of Chicago Medicine. I'm a nephrologist and hypertension specialist, and I'm here today to give you tips on hypertension management in high-risk patients as well as the general population. When and how do you treat kidney disease progression, and what are the caveats? So again, those that have kidney disease, GFR of less than 60 or more than 300 milligrams of albuminuria, you have to be aggressive, and the guideline goal is a blood pressure of less than 130 over 80. Now, the proof that 130 over 80 or less slows progression of kidney disease better than less than 140 over 90 is very soft. But for sure, if you have more than a gram of proteinuria, you must be below 130 over 80. Otherwise, it's fine to be between 130 and 136 systolic. Very important point. Diastolics, of course, really need to be below 80 if at all possible. These are very important points that you need to keep in mind, and you will never get there in people with kidney disease using one drug. You must use two, ideally three. Diuretic should be one of those agents. Again, chlorthalidone preferred over hydrochlorothiazide. And if you have a GFR below 30, if it's below 30, then thiazide diuretics are not going to work very effectively. You need to use loop diuretics, and torsemide is the best single loop diuretic in that setting because it's long-acting. Furosemide, if you're going to use it, you have to use it twice a day. And those of you that like Bumex or bumetanide, you have to use it 3 times a day because it's even shorter acting. So keep those things in mind when you're treating these patients. Also, ACE inhibitors, except for one, fosinapril, are renally excreted. So in people with GFRs below 30, you need to reduce the dose to once a day, for sure. And ideally, ARBs are not renally excreted, and so you do not need to reduce the dose in those subgroups. Lastly, with this subgroup, if you're treating these patients and the creatinine goes up, it is perfectly acceptable for the creatinine to go up 30% before you get concerned about anything, as long as the person doesn't have hyperkalemia, defined as 5.4 or higher. If they do, then you need to reduce the dose of the ACE or the ARB. Or you can use the new blockers of potassium in the gut, patiramir, and the new ZS9 compound that will be out shortly, because those are very well tolerated. They can be given daily, and you can actually allow for the use of ACEs and ARBs in people with advanced CKD. I hope you've enjoyed this tip, and hopefully you can use it in your practice to improve patient care. Thank you, and have a good day.